First of all, we heard yesterday there be no such thing as heroes. That's a bad word. Secondly, let me thank those of you who've soldiered on to this time. I feel like Andrew Cuomo, I heard Andrew Cuomo some time ago at the end of a long day saying, everything that can be said of this topic has been said before, but not everyone has said it. And then he proceeded to repeat everything that had been said in the past 2 days. I'm going to do something similar. I have been asked to, I don't have any slides because I did most of this last night. I've been asked to reflect on what I've heard about a social contract in health and perhaps flavor it with my experience as a student, patient, medical educator, medical practitioner, and health administrator over many years. And the outset, let me declare that I'm not a professional ethicist, although I've sat on many ethical committees, nor have I carried out research on professionalism, although I've had to reflect on it on several occasions over the years, often more about the breach than the observance, as I've sat on medical councils in my part of the world. And I'll frame my comments within the context of the workshop's aim, which is on innovation in health professional education, with a focus on establishing transdisciplinary professionalism for health. And the question is it possible to educate health professions in a transdisciplinary manner so as to inculcate the elements of a shared social contract? And that is the point I'd like to address. Let me begin by saying that while I'm no intellectual Luddite, as far as medical education is concerned, I've always needed to be convinced of the merits of any radical change, as evidenced by the change in the function of the product. This is because I've seen many attempts at changing methods and content of education instruction in my day. I have not always been convinced of the value of the effort. I also believe, as a general thesis, that education in areas like that changes in areas of education are more likely to have traction when they're evolutionary rather than they're revolutionary and give the comfort of building on continuity. I start with the concept of the social contract, and I deliberately ask that the title not have the definitive article. And I have to admit some ambivalence about the possibility of enforcing social contracts. When I was very young, I held to the notion of a social contract in the political sense, in the sense used initially by Plato, actually, and then by Hobbes, Locke, and Rousseau, as the Crucis said yesterday. It was a contract in which a group of or individuals give up some degree of individual benefit or autonomy in order to achieve some greater social good or to ensure protection of themselves. And if you read Rousseau, the social contract reduces itself to the following terms, and I quote Rousseau textually: each of us puts his person and all his power in common under the supreme direction of the general will. And in our corporate capacity, we receive each member as an individual part of the whole. I know the Caribbean experience fairly well, in which the heads of government identified specific social sectors, and they posited that there could not be progress in terms of human development without some contract between some or all of these sectors with government. And in times of our economic stringency, the successful social contract between organized labor, for example, and government, that was held up as a sign of social maturity. And I have followed peripherally the debate as to whether the growth of social protest now is some reflection of the weakness of the social contract and the inability of the state to protect the freedoms of individuals who had, as it were, given up some of their autonomy for that protection. In this sense, social, as applied to contract, implied an arrangement with and for the benefit of society. And contrary to Margaret Thatcher, I do believe there is a society. If I am to propose a contract that is transdisciplinary and transprofessional, then I should give my concept of that professionalism. And yesterday you heard the Cruces define the profession brilliantly as, and I cite them again, an occupation whose core element is work, based upon the mastery of a complex body of knowledge and skills. It is a vocation in which knowledge of some department of science or learning or the practice of an art, notice the difference between science or learning, or the practice of an art is founded, an art founded upon it is used in the service of others. Its members are governed by codes of ethics and profess a commitment to competence, integrity, and morality, altruism, and to the promotion of the public good within their domain. I noted a little difference between that and the definition you put the first day in terms of a belief system. And I am intrigued by the differentiation between vocation and occupation. But who am I to argue with the Cruces about professionalism? Because I can't do better than their definition. And I would only add that professionalism obviously embraces the exercise of a profession. Health professionals have almost by definition a formal relationship with three critical groups, with patients, with other health workers, and with society at large. And the organization of these relationships and the rules to order them in a formal sense go back to some about 150 years on both sides of the Atlantic. And these relationships, or parts of them, can be seen in the origins of medical practice and are seen in many different cultures and are always hedged around by rules and regulations. And the area of which I'm most familiar is the relationship of the health worker, primarily the physician, with patients. But despite the history of codification and regulation of relationships and the firm establishment of regulatory frameworks, I still recall, as a young physician, hearing that much of the angst for a formal code or compact, much of this stemmed from the need to protect the physician and was another manifestation of the old dictum of emptor caveat, let the buyer beware. And codes were less necessary when there was genuine professionalism. I heard Graham Ketto, as General President of the General Medical Council of Great Britain, admitting to being sympathetic to the words of Lord Phillips, who was making a deposition to the Royal College of Physicians about this issue. And Lord Phillips, he decried the growth of moral, as he described it, moral minimalism. And the moral minimalism led to emphasis on regulation. And I quote Lord Phillips, he says, "It seems self-evident to me, the essence of professionalism is to be able to call upon the honor, probity, and principled judgment of the practitioner. A self-respecting, fully functioning profession would surely profess just that and deal with inevitable failures." However, on the basis of this relationship, primarily with the patients, physicians acquire the power, authority, and the degree of compensation that set them apart from many other professions. And we found medicine moving away from being cosseted and closeted by being closeted and being cosseted by the notion of a guild. They were highly regarded, trusted, and remunerated, and they often acquired influence outside their area of competence, and influence based on the degree of trust that they acquired from society. Today, the nature of the relationships with the patient is changing, or has changed for several reasons. However, I would think there would be general agreement that as far as the individual patient is concerned, there's still the fundamental responsibility to achieve what Danny Callahan refers to as the core goals of medicine. And I cite them: the prevention of disease and injury, promotion and maintenance of health, the relief of pain and suffering caused by any maladies, the care and cure of those with the malady and the care of those who cannot be cured, the avoidance of death and the pursuit of a peaceful death. Parenthetically, this is one of the things that has engaged me much these days, is the last of those, which is most often ignored in modern medicine. We don't often teach our students how to help patients to die with dignity. But really, these are not enough and have to be complemented by the inclusion of values such as trust, respect, confidentiality, compassion, and others which the Cruces described and which Barbara elaborated so brilliantly just now. Medicine is becoming more complex every day. And as Cyril Chandler once said pithily, medicine used to be simple, ineffective, and relatively safe. It is now complex, effective, and potentially dangerous. And this increased complexity has resulted from the vertiginous growth of science and our increased understanding of the basis of disease and illness. And the advances in the basic sciences have made it impossible for any single discipline within the profession to have the knowledge and expertise to address the whole range of illnesses that may be present. And it's for that reason that there has arisen a large number of disciplines that are necessary to deal with the health problems of medicine. It is this complexity of care and the changes in the world's disease profile that have brought to the fore the second of these relationships, the relationship between health workers in different disciplines. The chronic non-communicable diseases have now surpassed the acute communicable diseases as causes of death in most parts of the world. For example, the number of deaths from these chronic diseases has increased by 30% over the past 20 years, while those from the communicable diseases have decreased by some 70%. Even HIV/AIDS now is becoming a chronic disease. Thus, the world has to be adopting models of continuous care, which essentially involve the patient, the family, the community, and the care services at different levels. And given the chronicity of the care, these patients will need to be seen by a variety of health professionals over a long period of time. And it therefore becomes fundamentally important that there be respect, understanding, and fluid communication between them. Thus, codes of practice and behavior must of necessity incorporate the need for relationships among widely different disciplines exercised by different professionals. And one other attribute I would include here, which is not often mentioned, it is the capacity to listen. As one of my gurus points out, Drucker, 46% of the variance in achievement of senior professionals is determined by their capacity to listen. We don't often teach that. The availability of information is also changing the nature of the physician-patient relationship. The degree of informational asymmetry was once so great that it induced a paternalistic approach by physicians and placed them in a different and a very difficult situation often, a situation of having to ensure that they did not take advantage of the asymmetry to advance their own utility. With increasing availability of information, however, the degree of asymmetry has decreased, although it has not disappeared. I speak from experience in many other parts of the world. The disappearance of asymmetry and the facility of accessing information is not a universal given. And the access to health information that will decrease the asymmetry, as I point out, is not necessarily a global phenomenon. There are tools available to affect change in the health of populations. And the classic work of Jeffrey Rose showed the nature of the interventions that were needed. In addition, there's now a better understanding and appreciation of the social determinants of health at both the individual and the population level, and acceptance that many of the levers to be pulled are outside the competence of the health sector. And this appreciation of the social determinants of health has called into question whether such disciplines as sociology and economics should not be legitimately counted among the health professions. But a more critical question is whether the interventions needed for improving the health of populations should be part of the remit of individual health workers or should be under the exclusive purview of the state. For example, tobacco. As part of the compact that involves individuals, the physician has a responsibility to set a good example by not smoking and to advise his patients not to smoke. But it's the state that has the authority and responsibility to raise taxes on tobacco as the best method of reducing smoking. But this also brings into question the role of the health professional as an advocate for change. Should it be part of professional responsibility to advocate for the change in the social determinants of health? One of my heroes, the great German philosopher, the great German physician, Rudolf Virchow, wrote in 1848, "Doctors are the natural advocates of the poor, and social problems are largely within their jurisdiction." But it is in the terms of the relationship I've mentioned, the patient, health workers, but it's in terms of the relationship between the medicine and society that I see the need for the social contract, which, as the Cruces explained, embrace the expectations and contribution of both. And as they pointed out, the societal expectations of the physician, and they also elaborated on the expectations of the physician as regards society. The medicine expecting trust, a monopoly on practice, and a reasonable measure of status and compensation. And medicine will also expect of society, would also expect of this is terrible, isn't it? I can't turn my own pages. We also expect of society a health system that enables medicine to be practiced efficiently. Now, Is it possible, I pose the final question, to envisage a contract, perhaps not a social contract, but a contract that is transdisciplinary in the sense that it cuts across all health disciplines? First, there's already a great degree of similarity in the codes of practice of the various health professionals. And if you examine codes of ethics of pharmacy, there's great similarity with the code of ethics of physicians and laboratory workers. So I believe that one will find in all these professions three essential processes, three that ensure the fitness to practice. One, a corpus of standards and ethics. Two, a system of registration. And three, a system of education and instruction. So I can envisage the elements of relating to patients, to other members of the profession, and to society as a whole having a degree of commonality across the health professionals. The relationship between a physician and a patient, but it's not fundamentally different from that between a pharmacist and a patient or a dentist and a patient. So it is these core elements that might form the basis of a commonality of approach with regard to a contract that is across disciplines and does not relate to the science of the discipline as opposed to the art, as the Cruces pointed out. This would have to obviously be complemented by separate contracts with the individual disciplines which embrace both their science as well as their art. What would the type of pedagogy be that would enhance this transdisciplinary approach? The report of the Commission on Medical Education points out the nature and evolution of the instructional reform needed in the 21st century. We move from the informational learning to formative learning, and now this transformational learning that is necessary. While emphasis has been placed on the last as being about leadership, I view it through a slightly wider lens. This learning is really about acquiring the knowledge and skills in disciplines beyond those traditionally given in health, acquiring them with a view to transforming health from being considered uniquely as constitutive and mainly of intrinsic value to health being also instrumental for human development. This innovation will not only be in the form of education driven by the new technology, but also in the content of the material. It will also be innovative in the formal incorporation of the mentoring and role model exposure, which has often been at random, as indeed the traditionalists will posit that is the mentoring and following of the role models that does most to engender the formal relationships with the patients, other health workers, and society that has to be the bedrock of good health care. So in sum, this is my thesis. Innovative transdisciplinary pedagogy can contribute to formulation of a contract that is transdisciplinary. Also, there can be a contract with society that embraces all health disciplines. I put the question, can there be a contract with society that embraces all health disciplines? I would posit yes. I put that at the level of the art of medicine that is common to all professions, is at that level one can find the possibility of there being transdisciplinarity. And yes, I do believe that it is possible for there to be innovative pedagogy to stimulate the acceptance and formulation of both types of contracts. Thank you very much.
And with that, we conclude our workshop. I want to thank you all for joining us today. There's lunch out back, out in the hall as before, and you're welcome to use the room. It'll be open until 5 o'clock tonight if you want to meet with anybody. But also, I wanted to put in a plug for our next workshop that's going to be October 9th and 10th back here at the Academies, and we're going to be addressing the topic of assessment of health profession education. That will also include assessing a transdisciplinary professionalism. So we look forward to seeing you again. Thanks, everyone.